having me here today. It's such a pleasure, and I'm excited to talk a little bit about some issues that kind of fall outside of regular treatment, but I'm going to go through first kind of what we do, who we are, and things that we have ongoing this year. And then I will talk a little bit more about how we in the future will be able to leverage Medicaid to help us with some of the social determinants work. So hold on just a minute while I do this. Can everybody see that slide well? Okay.
Looks very good.
Okay. All right, great. I really just kind of want to start out that, the Department of Mental Health, it covers behavioral health for persons who have 200% of poverty or below needs in that area, who have Medicaid. Some of our partners serve people with private insurance, and anybody who is in an emergency crisis, regardless of their ability to pay. And this year, like many of you, we really kind of had a transformation. Fortunately, we had a good head start on that. We have a large telehealth system already in terms of behavioral health. But that has been a big deal this year in really making sure that that has been out there and moving forward and keeping people in care. I can tell you just a couple of things in terms of the pandemic and the experiences that we've had. We have had probably the highest number of persons ever calling our crisis lines, coming into our urgent care centers and coming into our crisis units and inpatient than ever before. Not always necessarily meeting that threshold, but being concerned about their mental health and feeling as if they're in crisis and wanting some support around that crisis. So, a lot of what we do is in the community. We have, for years, you've kind of known our community mental health system. That was a system that really started in 1963 under President Kennedy, who said, the only place that exists in our society right now for people to receive mental health care is in the state hospital. And I would like for people to be able to start receiving that in the community. And so obviously we've come a long way since those days. But the next iteration of that is what you call certified community behavioral health clinics, which is kind of taking what you think of as a community mental health center and broadening it to an extreme version where it would treat all types of addiction issues, all types of mental health issues, wellness issues as well, which they have been doing for years, but really amping that up. And then taking and providing care to anybody who comes in, regardless of what their payer source is, whether it's private insurance, whether it's VA, whatever, no wrong door there. Systems of Care is our main program for youth that really kind of wraps around services around kids who need it the most. That's also a model that pulls in the community. So it can help with some of those social determinant needs as well. We get a community team and a family team so that we're not just looking at the mental health needs of the child and the family. We're looking at what does it take for this child to be successful and this family to be successful. Do they have the housing? Do they have food insecurities? Do they need assistance with employment? Do they have the ability for this youth to join a basketball team or to be in activities that are that we know help build resilience? And then this last one that I want to mention, individual placement and supports, is an evidence-based model referred to as IPS that really focuses on meeting people where they are and getting them into stable employment and housing. But one of the misnomers about employment and mental health and addiction a lot of times is people think, well, you've got to get well, then you can go to work. But if we send you to work before you're well, that's going to be too stressful. You're going to have relapses and you're going to go backwards. But what we know from years of research is that that is inaccurate, that getting a person employed during the recovery process actually increases their ability to get well. That routine, that support, that positive feedback, that building of a network of people is incredibly important. And so we try to get people on the path of life in the community as soon as possible. And the flip side of what we do is behind walls, if you will, and those are our crisis cares, our residential substance abuse treatment, detox treatment, and inpatient psychiatric hospital services. And we also do something that's kind of a bridge in the middle, and that's called an urgent care center. We started this model a few years back where what used to happen when you came to a crisis unit or an inpatient hospital was that basically you either got a yes or a no. Yes, you meet criteria to come in, or no, you do not. Well, we realize there's a lot of people that fall in that no, but they're here for a reason. And so what an urgent care center says is, you know, it's fine if you don't meet inpatient criteria. We can offer you on the spot 24/7 hours a day, a med evaluation, medication. You can see a therapist. You can meet with a case manager about all of these kind of needs that you may have. And we just want to deliver care to you right now, whatever that need is. And that's been a real game changer. And then on the prevention side, we do a lot of work around suicide prevention, mental health promotion, overdose prevention, which is a big deal in our state. And then SBIRT, which is screening, brief intervention, and referral to treatment, which is one of the CDC's top 10 preventative efforts. And it's incredibly important. And we need to have more of this in our state. So we serve both urban and rural. We deliver services to approximately 200,000 a year, and that continues to grow every year in all counties across Oklahoma. And most of this we do through our contractors across the state. It's almost, if you likened it to a franchise, if you will, there's a set of musts that each of them have to do, that they're reviewed on, to the types of care they have to provide, the models that they have to follow, et cetera. And then there's a little bit of variance around that as well. But we do most of this through our community partners. And through this system, we have over 10,500 physicians, nurses, therapists, and other treatment providers across the state doing this work. In fact, we have a large impact on the economy across Oklahoma. Not only that, these folks in turn then have a big impact on the economy across our state by having jobs in their communities and being able to spread those dollars through tax dollars and shopping, et cetera. And the other thing that has a positive impact on our state is that people who are in recovery or in treatment or getting their mental health or addiction needs met are able to become productive members of society, which in turn then, as opposed to using resources, start to give back and are able to help produce valuable resources for other persons who may be in need. I'll tell you a little bit about SBIRT that we talked about a minute ago, because I think this is important. And I know that many of you in the room work in around physicians or are physicians, maybe would have an influence on this. SBIRT is a model that stands for Screening, Brief Intervention, and Referral to Treatment. And what happens is you use the evidence-based screening around the substance use of the person that has walked in for you to provide services to. And through that evidence-based screening, then you explain to the individual you're working with where they fall on that continuum. A lot of people are in a normal range, but there's a very big group of people that are in an at-risk range. And the evidence shows by having a conversation with that person about what their use is, how it compares to normal use, and what they're putting themselves at risk for, that tips that person back into the normal use range. And then you have a percentage of people over here on the far side that fall into the need for treatment range, and that's then the referral component to get them into care. But if we did this every time someone saw a nurse or a physician, over time, we could dramatically lower the number of persons who are going on to develop addictions in our state. And it's something that is important for us to do. And we partner with the University of Oklahoma's Oklahoma primary, I'm sorry, my pictures are right over that last word and I don't get it right.
Oklahoma Primary Healthcare Improvement Cooperative.
I knew you would know that, and I just didn't. I just didn't want to say it wrong.
I appreciate it. Thank you.
Who really goes in and helps primary care practices implement how they can set up SBIRT within their flow of the clinic, so that we can get more and more people to be doing this work, because it is going to be an important turning point in our state when we can get the majority of clinics and physicians doing this. And of course, the most important thing in everything that we do is do no harm, but in particular, when it comes to opioid prescribing and pain management. And we have a number of different programs going on, both from the prevention side and the treatment side, to make sure that opiates are prescribed only when absolutely necessary, and at that in evidence-based ways. And I can tell you, it's always surprising to me, because you think, oh, we've come so far and nobody misprescribes anymore. But I had a friend just the other day that went and received shoulder surgery and left with a prescription for 90 OxyContin. And I thought, oh my gosh, so we still have work to do around pain management and prescribing of opiates. And so we do this work around the state. Again, we partner with OPIC to help develop and implement and evaluate and disseminate the appropriate evidence-based practices across our state. So really important work. We also in Oklahoma, one of the number one issues from our governor down is to reduce the rates of suicide within our state. And sometimes when people think about suicide, they think about it as something that, oh, that's so big and overwhelming, we can't manage that. But we really can. This is a finite number of people that for the most part are touching our health system within the 30-day window of having died by suicide. And so we've got to do better in terms of screening for suicidality. Again, just like I was talking about for substances, whenever a person touches a medical care clinic in any way, shape, or form, making sure that we are asking them the right questions, that we are pulling in support and family, and or if treatment is needed, that we're getting them to there. And we do this work in just a number of ways. And again, that's something we really have to move forward with. Now, in addition, in the rural and metro primary care clinics around the state, we've been working, and OU's Health Substance Use Treatment and Access to Resources, or STAR prenatal clinic, we have naloxone hubs that help prevent overdose. When people have naloxone available, they can assist in reversing overdose. But also we've been doing some really amazing treatment around pregnant women who have opiate use disorder, and how we can have healthy babies born and have mothers stay with their babies after birth. Now I want to talk for a minute about certified community behavioral health clinics. I kind of told you a little bit about them, but there's something that is really important about them when we talk about Medicaid expansion and we talk about investments in communities that can really have good outcomes overall. One of the things that is a little bit different about certified behavioral health clinics is the finance model that they fall under. And it's similar to an FQHC, so that it is cost report based. So the cost report of an entity who is a certified CCBHC clinic is reviewed, and that cost then of providing care is what their rate is based on. And the interesting thing about this is it allows for things that fall outside of what are normally Medicaid compensable fee-for-service types of activities. So you can focus on helping people get employed, and that is okay to have in your cost report. You can talk about or work on getting people housed, and that is an acceptable thing to have in that cost report. You can also look at things like nutrition and occupational therapy, and those are acceptable parts of that cost report. So as we continue to move along this continuum with CCBHCs, we will continue to grow and develop those things that wrap around traditional treatment to really boost the outcomes that we want and to get people the best life in the community, and try to work towards solving some of those societal issues that can help people get well and stay well. Well, some of the things we have found with CCBHCs, some of the most dramatic has been really the ability to reduce inpatient admissions with folks. And there has been an emphasis with CCBHCs around technology. And so one of the things that we have done, you may have heard of this or seen, we've done some national presentations about there's a large number of persons who come to a CCBHC, and on their first visit, they're issued a tablet that they take with them from then on. And that tablet is connected to similar to what your phone device would be. So if you're in rural Oklahoma, it doesn't matter that you don't have Wi-Fi or broadband's not in your area. You have a means to connect wherever you're at. And in the middle of those tablets is a big button for emergency crisis that you can push 24/7, and someone will always answer and talk you through whatever the needs are. And then on the side, your physician, your case manager, your therapist, et cetera, is populated. And it will tell you if they're busy or if they're available, or it will put you in their waiting room if you would like to speak to them at any time, as well as pushing you reminders about your next appointments, et cetera. What we have found by having those out there pre-pandemic is that they have drastically reduced the number of urgent care visits, crisis unit visits, and inpatient stays in people that have access to this. And then lo and behold, COVID happened. And what we found is that people did not miss care at all. They were able to remain engaged in care, still get all of their needs met, which again, continued to prevent those higher levels of care in this population, which is incredibly important. And technology is one of the things that is allowable in cost reports if it is directly related to getting care to the person served. So that again helps us leverage some federal funds to continue to develop these initiatives. Now, one of the things that we're working on this year specifically is our comprehensive crisis response system statewide. This will be game-changing and really will start in its full implementation July 1st of 2022. And one of the things that really helps with that full implementation is our first one here, which is on July 1st of 2022, there will be a number turned on nationwide that is 988. And that number is for psychiatric emergencies. Just like you have 911 that we've always relied upon for emergencies, when that first started, it was never designed to be kind of the catch-all for everything: criminal behavior, suspicious behavior, and mental health and addiction crises. But over time, that's what it has ended up being. But what will happen with 988 is that from your cell phone or your landline, whenever you or a loved one is experiencing a behavioral health crisis, you can dial that number. And that is kind of the starting point of our full comprehensive system of care, is meeting people where they're at and having access to what you need. And so when you dial that number, there's a number of things that will happen. First, it is staffed by licensed mental health professionals who will start to triage that call. and they can route you any number of ways. If really what you're needing is a warm line to talk to someone for a while about what's going on in your life, maybe you haven't connected to counseling, but you'd really like to talk to someone, that's fine. That warm line is there. If it is more serious than that, then the person answering the phone is trained to kind of triage through what is going on and how it is best handled. Now, a great deal of time through that phone call, the crisis can be diverted and support can be given, a safety plan initiated, and that's all that's needed at that moment. But from this call center, they will have the ability to book a same day or next day appointment at the closest provider right there while the person's on the phone. So no longer would you need to have, hey, if you call this number tomorrow, see when you can get in. They can book right from this call center. The person, when they get off the phone, will have their appointment available to them to move forward. The other thing that call center will do will be to loop back and recall everybody at 2 different intervals after that initial call. Number 1, to make sure that they're still doing okay. 2, to make sure that they made it to their appointment. And 3, if you didn't, what were those barriers? Let's reset you up and let's try to overcome any barriers to getting you there. If the call is not able to be handled through the call center and the crisis seems more escalated than that or more support is needed, this call center then will dispatch mobile crisis teams anywhere around the state, where you'll have a set of 2 people who will come out to where you're at and spend more time and face-to-face time on really working with the person in crisis, ideally the family, to figure out what needs to happen next. Now then, this point here oftentimes can resolve the situation and resolve the crisis. But if not, and the person is willing to voluntarily go to, say, a crisis unit or an urgent care, then the mobile crisis team will just transport them right then and there, and they'll know where they should go and what services they need and where that would be located. This alone will reduce the need for law enforcement intervention from the 911 calls and with the mobile crisis teams going out. And so we hope through these methods to dramatically reduce the number of times that law enforcement is involved when you have a situation that is a mental health or addiction crisis. Because as you know, these are the only diseases where the first response is to call police to come intervene, and it's quite stigmatizing. Now, there are certainly times where there may be violence involved, and that would warrant law enforcement, but the majority of time that is not the case. And to be transported by most law enforcement officers, you have to be handcuffed to be placed in the police car. So you're being handcuffed and put in the back of a police car to go receive an evaluation or go receive care, which is traumatizing in and of itself, much less stigmatizing. The other thing that we're in the process of rolling out this year is that every law enforcement officer across our state by the end of this calendar year will have a tablet in their vehicle that they can connect with licensed mental health professionals right there at the push of a button. So if they're out and about and they come across someone that is experiencing issues from a behavioral health perspective, they can just push the button. And where we use this now, the most likely thing to happen is oftentimes they just hand the tablet to the person that they have, that they are with, that they've come across, and let them talk to the mental health professional who is oftentimes able to intervene in that situation, develop a plan with that person, decide whether they need higher levels of care, et cetera. But all of that is right there at law enforcement's fingertips. And one thing that we added in addition is that we added a button for law enforcement themselves, so that if they're having a particularly stressful day or they've experienced a particularly stressful situation, or if they're just having struggles at home, they can push a button that's specifically designated for law enforcement, and there is a professional there who can talk with them about what they're going through. It's completely confidential, because one of the things that we know is that first responders and law enforcement die by suicide at higher rates than the general population. So we didn't want to leave out of the equation providing support and care for our law enforcement officers as well. And then another thing that went into effect this year, this will start November 1st, is that the way you get to care, as we mentioned in Oklahoma right now, if you're not just in your own car and voluntarily going for help, is that you get placed in the back of a police car and you go to help that way. Well, starting November 1st, when law enforcement comes across someone that needs mental health assistance and needs to move to a higher level of care or needs to go for an evaluation, if it's greater than 30 miles away, law enforcement will back out and transport will be provided from the Department of Mental Health to get that person where they're needing to go. Good news about this is it keeps law enforcement on the street fighting crime, or when they get a 911 call that's emergent, that they can respond to, and it also helps to destigmatize these illnesses. In addition, we are standing up additional urgent cares across our state as well as crisis units. This year, we will add another 10. It may end up being more than that, but another 10 urgent cares and at least 3 crisis units around the state, because what we want is for care and treatment to be as close to you as possible, to be able to be handled in the least restrictive way that works best for the person. And in order to do that, we have to continue to build our capacity around the state. And lastly, I just wanted to point out our website has been revamped at the Department of Mental Health and Services. And when you go to our website, if you click on our network of care, it has a really good service directory that's updated that people can utilize to find assistance near them. But in addition, there are some other things that are within that network of care. There is a legislative tracker that will track any bills related to mental health and addiction. There's a library of resources around medications. There's interactive tools that a person can utilize for self-help themselves. And our website itself has a lot of e-learnings that even the general public can use around self-care or ways to help with stress. And all of that is accessible through our website. There's also linkages to support and advocacy resources on the website as well. And this is my contact information. If you ever want to reach out, feel free, or you can follow us at Facebook or Twitter. Also, okimready.org is a great resource to look at for persons who are suffering from addiction issues, in particular opiate addiction. And there's a vast amount of information on there for people who have those types of issues.